All right, good morning, class. Let's settle in. Today, we're going to tackle a really important topic, something you are going to encounter constantly in your clinical practice. We're talking about how to manage the body's fight or flight response using anti-adrenergic drugs. So, let's begin. So, picture this, right? You've got a patient, and their sympathetic system is just going crazy. Their heart is pounding, blood pressure's through the roof. It's that classic fight or flight response, but it's completely out of control. So what is our job? How do we, as future doctors, tell this system to just calm down? That's the puzzle we are going to solve today. Okay, so how do we actually do this? Well, broadly speaking, there are two main ways we can go about it. Think of it like intercepting a message. You can either block the destination, the mailbox itself, so the message can't be received, or you could stop the postman from ever leaving the post office in the first place. Let's see how this applies pharmacologically. And this table here, it lays out those two strategies perfectly. On one side, you have the adrenergic neuron blockers. These are the ones that stop the postman, right at the source, at the neuron. But for our discussion today, we're going to focus on the other side, the anti-adrenergic drugs. These are our mailbox blockers. They work right at the adrenergic receptors. Think of them as very specific gatekeepers that only block either alpha or beta signal. All right, so let's start with our first family of these gatekeepers, the alpha blockers. Now, when I say family, what do I mean? Simple. It just means they all target the same kind of receptor, and because of that, they all share some common effects, or you could call them family traits. And here are those family characteristics I was just talking about. It makes sense, right? If you block alpha receptors, you relax the blood vessels. So, blood pressure falls. And what does the body do in response? It tries to compensate, so you get reflex tachycardia. The heart starts beating faster. You'll also notice things like nasal stuffiness or constricted pupils, that's meiosis, because you're blocking alpha receptors there too. And pay close attention to this last one, the effect on the bladder and prostate. That's going to be very important later. Now, just like in any family, you have different personalities, right? The same goes for the alpha blockers. They aren't all created equal. Some are, let's say, generalists, while others are highly specialized. The real skill is knowing which specialist to call for which job. So let's meet a couple of the key players. So first up, we have phenoxybenzamine. Think of this one as the heavy-duty specialist, the one you call for the really tough jobs. And the most important word you need to associate with it is irreversible. It doesn't just sit on the receptor temporarily, it forms a strong covalent bond. That block is going to last for days, 3 to 4 days in fact, until the body physically makes new receptors. That makes it incredibly powerful, but only for very specific scenarios. And what is that very specific scenario? Pheochromocytoma. This is a tumor, usually in the adrenal medulla, that is just pumping out huge amounts of catecholamines. So can you imagine what happens during surgery when the surgeon touches that tumor? A massive surge in blood pressure. So what do? For 1 to 2 weeks before the operation, we give phenoxybenzamine to bring that BP under control. It's an absolutely crucial step to prevent a hypertensive crisis on the operating table. Okay, next up is prazosin. Now, if phenoxybenzamine was our heavy-duty tool, prazosin is more like a precision instrument. It's more refined. Why? Because of one word, selectivity. It specifically targets the alpha-1 receptor subtype. So what's the big deal? Well, by leaving the alpha-2 receptors alone, it doesn't cause as much of that reflex tachycardia that we saw earlier. It's a much cleaner, more targeted approach. So what are prazosin's main jobs? Well, it has two big ones. First, hypertension, and second, and this is a very common use, for benign hypertrophy of the prostate, or BHP. By blocking those alpha-1 receptors in the prostate and bladder, it relaxes the smooth muscle and, well, it makes it easier for the patient to pass urine. But here's a very important clinical pearl for you, the first dose effect. The first time a patient takes it, their blood pressure can drop quite dramatically. So what's the rule? Always start with a low dose, and tell them to take it at bedtime. And that leads us perfectly to our next drug, tamsulosin. And if prazosin was a specialist, then tamsulosin is the super specialist for urinary problems. It's what we call uroselective. It has this incredible affinity for the alpha-1A and alpha-1D receptor subtypes, which just so happen to be the main ones located in the prostate and the base of the bladder. This is a beautiful example of precision pharmacology. And the clinical advantage of this super selectivity is huge. Because it's so focused on the urinary tract, it does its job, relieving those BHP symptoms without really affecting the patient's blood pressure much at all. This is fantastic. It makes it a much safer and better tolerated option, especially for, say, an elderly patient who you're worried might get dizzy and fall from postural hypotension. Okay, so we've gotten to know the alpha family pretty well. Now it's time to shift gears and meet their very famous, very important, and frankly, much larger cousins, the beta blocker family. I cannot stress this enough. This is one of the most fundamental drug classes you will learn and use. So please, full attention now. This diagram here, this is basically your roadmap to the entire beta blocker universe. Let's just take a second to orient ourselves. See that first big branch? The main split is between non-selective, meaning they block both beta-1 and beta-2 receptors, and cardioselective, which, as the name suggests, primarily focus on the beta-1 receptors in the heart. This main distinction is key. We'll keep coming back to this idea. You know, when you want to understand a family, you often start with the patriarch, right? Well, in the world of beta blockers, that is propranolol. It's the prototype, the original. It was a massive breakthrough drug. And trust me, if you can really understand propranolol, you'll understand the core principles behind pretty much every other beta blocker out there. And here it is. This is the molecule that truly revolutionized cardiovascular medicine, propranolol. And remember, what kind is it? It's a non-selective beta blocker. It blocks both beta-1 and beta-2. Now, let's explore what that actually means for a patient. Okay, its main stage of action is, of course, the cardiovascular system. By blocking those beta-1 receptors in the heart, it does three crucial things. It decreases the heart rate, it reduces the force of contraction, and as a result, it lowers the total cardiac output. The bottom line? It makes the heart work less. It reduces the heart's workload and its oxygen demand. And you can immediately see why that would be so incredibly useful for something like angina. But, and this is a very important but, because propranolol is non-selective, it also blocks beta-2 receptors found elsewhere in the body. And this is where we start to see the side effects. You block beta-2 in the lungs, you get bronchial resistance, which is bad news for an asthmatic. It also affects metabolism. It can actually delay recovery from hypoglycemia in a diabetic patient. Interestingly, it can also block tremors, which can sometimes be a useful effect. Listen, if there is one thing you take away from today's lecture, let it be this. The contraindications are absolutely critical. Because of that beta-2 blockade effect on the lungs, you must never, and I mean never, give a non-selective beta blocker like propranolol to a patient who has asthma. You could trigger a severe, potentially fatal asthma attack. This is a non-negotiable rule in clinical practice. So let's pull all of this together. Ultimately, it all boils down to this: choosing the right tool, the right specialist for the right job. We've met two big families today, the alpha blockers and the beta blockers. Your skill as a clinician will be in knowing which one to pick and when, based on your patient's specific needs. And this chart gives us a nice, clean summary. Look at the alpha blockers. What's their main battleground? Things like BHP and pheochromocytoma. And the strategy? Relaxing specific smooth muscles. Now look at the beta blockers. Their territory is different. Hypertension, angina, arrhythmias, mainly cardiovascular issues. And their strategy? To reduce the heart's workload. Two different families, two different strategies. So I'm going to leave you with a clinical puzzle to think about. Imagine a 60-year-old patient. He has hypertension, so you're thinking a beta blocker might be good. But he also has a history of asthma. So based on everything we've talked about today, which type of beta blocker might you consider? And more importantly, why? The clue, of course, is in that word selectivity. Have a think on that. Thank you very much, everyone. Namaskar, my dear students. Welcome back. Today, we're going on a really fascinating journey in pharmacology. We're going to see how one single class of drugs, the adrenergic blockers, can travel from protecting something as big as the heart all the way to saving the delicate little structures inside the eye. It's a perfect example of how a systemic drug can have a very specific and, honestly, a life-changing local job to do. All right, so here's our plan for today's session. First, we'll start with the big picture, getting a solid understanding of beta blockers. Then, we're going to zoom right into the eye and see it as a special case. We'll decode the pressure problem in glaucoma, look at the entire toolkit of drugs we use to fix it, and finally, see how a doctor actually puts together a treatment plan. Let's get started. And this really is the big question, isn't it? Just think about that for a second. A drug that can prevent a second heart attack is also given as an eye drop to stop someone from going blind. How is that even possible? How can one single pharmacological key unlock so many different doors in the human body? Well, Let's find out.
Right then, let's dive into our first topic, beta blockers. You can honestly think of these guys as the bodyguards of the heart and blood vessels. They are true powerhouse drugs, and their versatility is, well, it's just amazing.
So let's talk about a myocardial infarction, or MI, what everyone calls a heart attack. Here, beta blockers are like superheroes with two different powers. First, for a patient who has already had a heart attack, taking these drugs long-term can decrease their chance of dying by about 20%. That's huge. But the second point is maybe even more incredible. If you give a beta blocker within hours of the attack itself, you can actually limit the size of the damage to the heart muscle. It works by reducing the heart's demand for oxygen. It's like telling an engine that's overheating to just slow down a bit, saving it from being destroyed.
Now, this next part, it might seem a little bit ulta, a bit backwards. We think of beta blockers as drugs that slow the heart down, so how on earth can they help in congestive heart failure? Well, the thing is, in CHF, the body's sympathetic system is going crazy. It's in overdrive, and that's actually toxic for the heart in the long run. So certain beta blockers, when used very carefully, can block these harmful effects, they reduce heart cell death, and they can actually help these patients live longer.
And believe me, the list just goes on and on. It doesn't stop with the heart. These drugs are seriously multi-talented. We use them for everything from controlling the scary symptoms of an overactive thyroid to preventing migraine headaches and even calming the shaking hands of someone with performance anxiety. It's this incredible range that we're really focusing on today.
Okay, so now let's completely shift our focus. We are moving away from these big systemic effects on the entire body, and we're zooming in on one tiny but incredibly complex organ, the eye. We're going to see how the very same principles of pharmacology apply here in this very special case. The main problem we're going to tackle here is glaucoma. In Hindi, we often call it kala motia. But please remember this. The main problem isn't just the high pressure. The real danger, the thing that causes blindness, is the progressive damage to the optic nerve. The high pressure is the #1 risk factor, and it's a thing we can treat. But our ultimate goal is always to save that nerve and preserve the patient's vision. All right, have a look at this diagram. To really get glaucoma, you have to understand the eye's internal plumbing system. It's actually quite simple. Over here, in the ciliary body, a fluid called aqueous humor gets produced. You can think of this as the tap. This fluid then has to flow out of the eye through two drains. The main one is the trabecular outflow, and there's a smaller, secondary one called the uveoscleral outflow. So let's make this super simple. Just think of a wash basin in your house. What happens if the tap is running too fast? Or what if the drain gets blocked with hair? The water level rises, right? The sink overflows. It's exactly the same principle inside the eye. Either there's too much fluid being produced or not enough is draining away, and the pressure inside the eye starts to build up. That pressure problem is glaucoma. So, when you have a plumbing problem, what do? You call a plumber. Well, in our world, the plumbers are our drugs. So now we're going to look at the pharmacology, all the different medicines we can use to either turn down that tap or to help unclog the drain. So this here is our toolkit, the doctor's pharmacopoeia for treating glaucoma. You can see we've got a few major classes, beta blockers, of course, but also alpha-adrenergic agonists, prostaglandin analogs, carbonic anhydrase inhibitors, and the older drugs, miotics. We're going to break down the main players from this whole set. Back in the day, the main drugs we used were miotics, like pilocarpine. And they worked, sure, but my God, the problems they caused. They would make the pupil tiny, which made it really hard to see in dim light. They caused headaches, and patients had to put the drops in many times a day. Then along came the beta blockers, like timolol. And it was a total game changer. No effect on the pupil, no pain, and you only had to use it once or twice a day. So much better. But you know how it is in medicine, right? Science never stands still. And today, even though beta blockers are still super important, we have new champions. The preferred first-choice drugs for most patients now are the prostaglandin analogs. They are incredibly effective, and most of them only need to be used once a day. So how does this all work? Where is the magic happening? Well, look at this diagram of the ciliary body. See, it's covered with all these different kinds of receptors, things like beta-2 and alpha-2 receptors. Our beta blocker drugs work by blocking those beta-2 receptors, and that action directly reduces the production of the aqueous humor. It's all about targeting the right molecular switch to turn down the tap. Okay, so let's try to put all of this information together in one nice, easy-to-understand table. Now, this is super, super important for your exams. This is a high-yield slide, so please pay close attention. We're going to organize all these drugs based on how they solve our little plumbing problem. And this table just makes it all crystal clear, doesn't it? It shows our two main strategies. Look here, drugs like beta blockers and carbonic anhydrase inhibitors, what are they doing? They're decreasing secretion. They are turning down the tap. But then you look at prostaglandins and miotics, they are increasing outflow. They are unclogging the drain. And then you have some clever drugs like alpha agonists that actually do a little bit of both. If you understand this table, you understand the core strategy of glaucoma treatment. Okay, fantastic. So we know the drugs, we know how they work, but how does a doctor actually put this into practice with a real patient? Because pharmacology isn't just about memorizing drugs, it's about knowing how to use them wisely. Let's look at the clinical approach. And you'll see it's a very logical, step-by-step approach. You don't just throw everything at the patient at once. Step 1, you start with just one drug, monotherapy, usually a prostaglandin or beta blocker. If the pressure is still not at the target level, what do? You move to step 2, either switch to the other first-line drug or maybe use both together. Still not enough? Then you go to step 3 and add another drug on top. And you'll see that the older drugs, like miotics, they are now reserved only as a last resort. It's a very clear, structured plan. So look where we've ended up. We started our journey talking about a drug molecule that protects the heart from the effects of adrenaline, and we've ended with an eye drop that saves a person from going blind by blocking those very same types of receptors inside the eye. From a single molecule to protecting a patient's entire world, I mean, isn't pharmacology just absolutely fascinating?
Thank you. Namaste, everyone. Welcome back. So today, we're going to tackle a molecule that you all think you know very well, histamine. And I know, the moment I say histamine, you're thinking, "RA, sir, that's the villain, no? The one that gives us all the sneezing and itching." And yes, you're not wrong, but that's only one scene in a very big movie. This molecule is a real jack of all trades. So come on, let's pull back the curtain and see what else this histamine fellow is up to. So this is the big question, isn't it? How can just one chemical do so many different things in the body? I mean, it's involved in allergies, sure, but also in your stomach acid, your heart, even your brain. How does it manage all these different jobs? Well, the secret isn't really about the histamine itself. It's about who it's talking to. And this is where it gets really interesting. You see, histamine doesn't just shout into a void. It has specific docking stations, or receptors, that it talks to. For our purposes, we're going to focus on the big 3, H1, H2, and H3. The best way to think of them is like 3 brothers. They come from the same family, but my God, they have completely different personalities. And depending on which brother histamine talks to, you get a totally different outcome. So you must be wondering, sir, if they're all histamine receptors, why are they so different? Well, it all comes down to what's under the hood. It's all about their engine. H1 is coupled to a GQ protein. Think of it like a powerful, fast engine. H2 uses a GS protein. Maybe that's more like a steady workhorse engine. And H3, that's a GI/GO protein. That's the engine with the super efficient brakes. You see? Same car model, but totally different performance because of the protein it's coupled with. This, my friends, is the secret sauce. This is what makes all the difference. Okay, so if these receptors are like locks placed on the doors of our cells, then in pharmacology, we become locksmiths. We have special keys. Now, some keys, which we call agonists, are perfect copies. They fit the lock and open the door. But then there are other, more clever keys called antagonists. These are the ones we use for medicines. So what is an antagonist? Just pay attention here. It's like a badly cut key. It fits perfectly into the lock, right? But when you try to turn it, nothing happens. It won't open the door. And worse, it's now stuck in the lock. So the real key, histamine, can't even get in. It's a blocker, a bouncer at the club door saying, "Sorry, not today." This is precisely how our antihistamine drugs work. They are receptor antagonists. So simple, but so powerful. And look at this. This is why knowing the difference between the locks is absolutely critical for you as future doctors. If a patient comes to you with a running nose and itchy eyes, that's an H1 problem, so you need an H1 blocker. But if another patient has terrible acidity, that's an H2 problem in the stomach. You have to give an H2 blocker. You can't mix them up. You have to use the right key for the right lock. It is that specific. Very good. So we know the what and we know the why. Now let's get into the really fun part, the how. We're going to dive deep inside the cell now, into what I like to call the cell's engine room.
to see exactly what happens, step by step, the moment histamine knocks on the door. All right, first up, the H1 pathway. When histamine binds to H1, it's like tipping over the first domino in a long line. That GQ protein engine kicks into gear and starts a chain reaction that produces two very important messengers, IP3 and DAG. Now, this IP3 is the important one here. It zips across the cell, unlocks a storage vault, and boom, a massive flood of calcium is released inside the cell. And it's this calcium flood that gives the final order, telling a muscle to contract or a nerve to fire. Just a simple, beautiful cascade of events. Now, for the H2 receptor. This one works differently. Think of it as the cell's energy booster. Its GS protein engine switches on a factory called adenylyl cyclase. And what does this factory do? It starts pumping out these little energy packets called cyclic AMP, or CAMP. More CAMP is like pressing the accelerator in a car. It energizes other proteins in the cell and makes them work harder and faster, like telling your stomach cells to start pumping out more acid. And finally, our third brother, H3. Now, if H2 was the accelerator, H3 is definitely the brake. Just look at its engine, G. That I stands for inhibitory. This guy does the exact opposite of the other two. It reduces the calcium flood. It cuts down on those CAMP energy packets. It's the sensible older brother telling the cell, okay, calm down, take it easy. Its whole job is to put a stop to the action. It's an inhibitor. Okay, so we've been inside the engine room, we've seen all the mechanics. Now let's zoom out. Let's look at the bigger picture, the entire human body. Where are these receptors actually located, and what are they controlling in our day-to-day life? This is where all that theory becomes clinical practice. So, where do we find H1? Well, you find it everywhere an allergic reaction happens. It's what tightens the muscles in your airways during an asthma attack. It's what makes your capillaries leaky, causing all that swelling and redness. And it's what stimulates the nerve endings, giving you that maddening itch from a mosquito bite. H1 is, without a doubt, the undisputed king of allergy and inflammation. And what about H2? Well, it's got two major addresses. The most famous one, of course, is in the gastric glands of the stomach, where it's the big boss in charge of acid production. But, and this is a good fact to remember, it's also found in the heart. And over there, it can actually increase your heart rate and make it pump more forcefully. Totally different functions in different locations, you see? Now check this out. This is a beautiful, beautiful example of pharmacological elegance. Both H1 and H2 can cause blood vessels to dilate, to widen. But they do it in completely different styles. H1 is a bit indirect. It talks to the inner lining of the blood vessel, the endothelium, and tells it to release other chemicals that cause relaxation. H2, on the other hand, is very direct. It goes straight to the muscle wall of the vessel and tells it, relax. Same outcome, but two completely different pathways. Isn't that just fascinating? And now for our brake pedal, the H3 receptor. And where does this one live? Well, its main home is on the very same nerve endings that release histamine in the first place. It's like a built-in feedback loop. When too much histamine gets released, it activates these H3 receptors, which then send a signal back to the nerve saying, whoa, that's enough, stop releasing me. It's a self-regulating system, an autoreceptor. The body is so clever, it has its own braking system built right in. So, after all this biochemistry, all these pathways, let's bring it all back home. Why does any of this matter? Why have we spent all this time learning about these three different receptors? Because, my dear students, understanding this difference is not just for your exams. It is the absolute foundation of how you will treat your patients for some of the most common ailments they will ever have. And this table here, this is your take-home message. H1, its main job is allergy, its effect is excitatory, and we block it with our common allergy medicines. H2, main job is acid secretion, also excitatory, and we block it with acid blockers. And H3, the regulator, the brake, its effect is inhibitory, and this is where things are getting very exciting for future drug development. Three brothers, three different jobs, and three different classes of medicine. Which brings us to a final, thought-provoking question for you to ponder. We have fantastic drugs to block the accelerators, H1 and H2. But what if we could develop drugs that control the brake? What if we could fine-tune this H3 receptor? Imagine the possibilities. This, my friends, is the next frontier of pharmacology, a frontier that you are all going to be a part of. Thank you.